Today's talk is on cardiac tumors. Without further delay, I'll move on to the lecture. So basically, cardiac tumors are rare, including primary and metastasis. And if at all, if they occur, out of those cardiac tumors, most of them, majority are benign tumors. You may wonder, then why would we spend time on learning these rare things? That is because though these cardiac benign tumors are rare, there are questions asked from atrial myxoma for the undergraduate curriculum. So that is the main reason for this lecture. So straight away moving to atrial myxoma. As I told you earlier, this is the commonest primary cardiac tumor occurring in adults. And it is a benign tumor composed of myxomatous tissue. Most of these tumors are pedunculated masses. So they have a rounded head jutting out, and it is connected to the fossa ovale usually with the stalk. So most of these tumors occur in the left atrium. 80% of these tumors occur in the left atrium. Only a minority will occur in right atrium. And these tumors are common among females compared to males. So how do they present? So one-third of them would be asymptomatic. Okay. So they are detected during routine echocardiograms, incidentally may be detected during an X-ray when they demonstrate calcifications and stuff. But most of them are symptomatic. One-third is asymptomatic. Rest of two-thirds are symptomatic. Out of that, one-third would present with systemic inflammatory features and cardiac symptoms. Systemic inflammatory features in the sense fever, loss of appetite, loss of weight, and high inflammatory markers, high ESR and high CRP even. And cardiac symptoms wise, exertional shortness of breath, syncopal episodes, palpitations, and chest pains, and rarely people can have sudden cardiac death even when the tumor obstructs the flow. And one-third presents with embolic manifestations. Out of that, stroke is the commonest manifestation, and it is the commonest thing which is asked in the exams even. But having said that, people can have embolic manifestations in the form of mesenteric ischemia, renal ischemia, acute limb ischemia, and even retinal ischemia. So what do we expect in the examination? The striking feature in the general examination is clubbing. But apart from that, the patients might be febrile at your time of examination, and they might be cachectic if they have a long-standing cardiac myxoma. And cardiac examination-wise, in the pulse examination, you might appreciate atrial fibrillation at times. And moving on to the precordial examination, the striking feature is loud S1 with a mid-diastolic murmur. So we all know that mitral stenosis causes a mid-diastolic murmur, but there are subtle differences between mitral stenosis murmur and this myxoma murmur. Mitral stenosis, if the patient is in sinus rhythm, would cause a presystolic accentuation and opening snap, which are not pronounced in atrial myxomas. And in addition, atrial myxoma causes a tumor plug when the tumor bulges out of the valve. So, but unfortunately, the tumor plug may not be appreciable in all the patients. And now we spoke about the epidemiology, the presentation, the examination, and then how do we diagnose? We all know if you do a full blood count, it might show elevated counts, especially the neutrophils, high platelets, and if you do ESR, CRP, they might be high. The globulins level would be high, albumin might be low, indicating systemic inflammation. So these might occur, but these are not specific. So the way to diagnose is by doing a 2D echocardiogram. A transthoracic echo is more than enough to diagnose. So this is a picture of atrial myxoma where you see the myxomatous tumor, the peduncle is attached to the interatrial septum. And so this tumor comes from the left atrium. So this is the left ventricle, this is the left atrium. So this is the myxomatous tumor. So that is more than enough. You don't need cardiac MRIs to diagnose this. Echo is more than enough. And incidentally, sometimes if you do an X-ray, you might see calcifications inside the atria. So that might suggest an atrial myxoma. Biopsy would be the best, but we don't usually need a biopsy to diagnose cardiac myxoma. Then once you diagnose, how do you treat? Essentially, the treatment is surgical resection. The surgery has a highest success rate. Very rarely patients do have recurrences. It's roughly about 5%. So this brings us to the end of cardiac myxomas, the important topic for undergraduate cardiac tumors. But having said that, for the completion's sake, I would also talk about cardiac rhabdomyoma. So cardiac rhabdomyomas may not be questioned in the adult medicine paper because it's a commonest pediatric benign tumor. So it's a tumor composed of striated muscles. It's basically a hamartoma. So a normal tissue in an ectopic location, that is hamartoma. So normally differentiated striated muscles seen in the heart. So most of them are asymptomatic compared to myxoma. Myxoma, 1/3 were asymptomatic, 2/3 were symptomatic. Here, most of them are asymptomatic. And they can present, if they are presenting with symptoms, they may present with arrhythmias, causing palpitations, chest pain, syncopal episodes, or maybe overt heart failure. And surprisingly, some of these tumors might spontaneously regress even. And the rest may require surgical intervention. And it is associated with tuberous sclerosis. Cardiac myxomas are associated with something called Carney complex, but that is too much for undergraduate. That is a postgraduate topic. So we don't need to bother much about that. So at the end, just see a couple of questions. So first one, true false regarding cardiac myxoma. First is, it is a malignant tumor. The answer is false. We all know it's a myxomatous benign tumor. Commonest primary cardiac tumor in adults. Causes high ESR. Yes, the answer is true because it causes systemic inflammation. So the patient might present with fever, loss of appetite, loss of weight, and would have high platelets, high CRP, high ESR, low albumin, high globulins, anything to suggest a systemic inflammation. Clubbing is a feature. Yes, of course. One of the cardiac causes of clubbing is atrial myxoma. The others are cyanotic heart disease, and infective endocarditis. These are the three cardiac causes of clubbing. So, three cardiac causes of clubbings are atrial myxoma, infective endocarditis, and congenital cyanotic heart disease. Ejection systolic murmur is heard in the sternal edge. No, it's a mid-diastolic murmur, which is heard in the case of atrial myxoma. That is false. May present with ischemic stroke. Yeah. 1/3 may present with embolic phenomenon. Out of the embolic phenomenon, stroke is the commonest embolic phenomenon. So that is true. So the answer is false, true, true, false, true. Pardon me for the spelling mistake. Atrial myxoma. It's atrial myxoma. First one, may present with fever. Yes, as we spoke earlier, they may present with constitutional symptoms, fever. It may be low grade or high grade even. Arises from the left ventricle. No, that is false. Most of these myxomas arise from the left atrium, and few of them will arise from right atrium. So that is false. Causes mid-diastolic murmur. Yeah, with a tumor plot. Sudden onset of blindness is a feature. This may be tricky, but the answer is true. We spoke about embolic phenomenon. The commonest embolic phenomenon is stroke. So stroke means cerebral parenchyma, retinal circulation, and spinal circulation. So they can present with retinal artery emboli, causing sudden onset of painless vision loss. Emboli to the anterior spinal artery might cause anterior spinal artery thrombosis with bilateral paraplegia and stuff. And cerebral emboli might cause various stroke syndromes, commonly MCS strokes. And apart from that, rarely they can have renal ischemia, mesenteric ischemia, and acute limb ischemia as well, but those are very rare. So sudden onset of blindness is a feature that STEM is true because of retinal embolization. Usually widely metastasized at presentation. No, it is a benign tumor, so there's no reason that it should metastasize. Emboli is different from metastasis. Okay. Because the tumor embolizes because it's a friable tissue, gelatinous friable tissue. So the tumor particles will embolize. That is not metastasis. That is different. Metastasis is a feature of malignancy. This is a benign tumor where the tumor particles break down and embolize into the circulation. Okay, so that is false. that brings us to the end. Thank you for listening.